Simons.
You do say Simons?
Yeah,
okay, because I
that a
heard
lot,
it and I thought.
I bet.
Okay, so Kelsey Simons, we're very happy to have her here today. She has done her PhD in Maryland, the University of Maryland, in Baltimore rather, and she also got a student award there for excellence in clinical practice, clinical services. So she's very highly regarded at her own alma mater. They gave her an award in 2010, a merit award. So she has been a research scientist at CLARA, which is the Kuhnen-Lunenfeld Applied Research Unit at Baycrest, and they have a CATS, Gerontological Social Work Center there where she does her research. She has a major interest in psychosocial issues in long-term care facilities. So one of her major grants that she's just completed was on applying the Canadian Coalition of Mental Health Best Practice Guidelines to long-term care facilities, to psychosocial care in long-term care facilities. And she's now on a new research project, just finishing phase 1, which she's going to talk about today, which is looking at the job satisfaction and organizational commitment among Ontario's social workers in health and aging. So this is looking at who is interested in aging, that in having their career in aging among the social workers here in Ontario, which is very fascinating because, as I take it, there is a shortage. So we're very happy to have her here today to talk about phase 1 of this project. So welcome, Kelsey.
Thank you. First of all, thank you for coming out on such a cold day. I think the rest of the winter does not feel like this. So that was a nice introduction. Thank you very much. What I was hoping to get from all of you is maybe just a little bit about your backgrounds. Are there any folks in the room that are researchers or faculty members here? Okay. And students in the room? Okay. How about social workers? Social workers? Social work students. Okay. So, the rest of you that didn't raise your hand to social work, what are your fields?
I'm in the School of Health Policy and Management.
Okay.
I teach social work, but I'm not a social worker.
Oh, okay. So I'm mainly talking to a room of social workers, I think. I'll try, for those of you that aren't in social work, if you can kind of be thinking about these issues in terms of your own field. I do think there's interdisciplinary implications to kind of issues that I'm talking about here today. I also want to acknowledge funding from SSHRC, very grateful for that, and my 2 RAs, one of whom is back home in Kazakhstan for the break. That's Sophia An, she's a doctoral student at the Faculty of Social Work, and Aman Aluwalia, who I think will probably show up here. I think she told me she would. She's an MSW student at the Faculty of Social Work. Okay, so there she is. That's okay, we just started. This is probably not new news to most of you here, but Canada's population is aging, as it is across all industrial countries. So, according to Statistics Canada, we're expecting the number of Canadian seniors, the population, to double within the next 25 years, with the largest growth among the oldest of old, which is those over 80 who consume the most amount of healthcare services. So this does place a greater demand on the health and long-term care systems and creates a need for additional healthcare workers, and not just healthcare workers, but healthcare workers who are competent in geriatrics. In recognition of this, and given current shortages in nursing and medicine, the Ministry of Health and Long-Term Care initiated the Health Force Ontario program. They have specific programs aimed at recruiting nurses and physicians. And they also have this Allied Health Professional Development Fund, which provides up to $1,500, I think it's per year, to allied health professionals, including audiologists, dietitians, and so forth. These are all professional groups that are regulated through the Regulated Health Professions Act. So if you look down this nice alphabetical list, it does skip over social workers. The reason for that is that we fall under a different college and a different regulation. So in my mind, this seems like an oversight, although it might be sort of a, a default, just because we don't fall under that particular regulation. So, what does that mean for gerontological social work? Well, we are core members of interprofessional geriatric healthcare teams. We provide important psychosocial services, including comprehensive assessment, care management, individual counseling, group work. We're often the liaisons in the system between patient families and other healthcare professionals. We advocate for seniors throughout the healthcare system, which is often sort of a fractured system. And we're community resource experts, which ideally we can help seniors stay in their homes if we know what services are in the community and we're able to access those for them. In a review of the literature I did on social work and long-term care a couple years back, we looked at, I think, 10 years of research related to social work and long-term care across settings, and there seemed to be solid evidence to show that geriatric care management teams, including teams of social workers, nurses, and doctors, as sort of the core professional group, was an effective way of providing care to frail older adults. Now, there's less research that has been done related to social work in specific practice settings like hospitals and long-term care homes. So we can't really make those kind of claims in these settings, but at least there is some evidence to show that social work can impact seniors through care management teams. And so, as was explained in the introduction, I was trained in the States and hired as a scientist at Baycrest and the CAT Center for Gerontological Social Work. So one of the first things I did was, look up what's going on in gerontological social work in Canada, and found that there were no major previous studies of the workforce, anyway, of gerontological social workers in this country. So that sparked my interest in doing this particular study, just to have some knowledge of who it is that provides these kind of services here, and what the training needs might be. And this coincides very well with the report that, I believe it was the Canadian Association for Schools of Social Work, undertook this national sector study, and one of the recommendations that came out of this report was that social work education programs need to respond to demographic changes, and especially the fact of Canada's aging population. So that's all well and good, but I also believe, and correct me if I'm wrong, that University of Toronto is the only MSW program in this country that has an aging specialization. At least that was the case in Wilma. So, are we meeting this demand, this need for aging, we call it aging savvy practitioners in social work? And so I've had an interest in not just training issues, but also retention of social workers in the field. And one of the reasons was some of the research showing that, we have this tremendous amount of turnover in our field. A study by Wormeling and Smith, which I think was conducted in the U.S. southeastern states, they did a survey of 785 MSW graduates, people who graduated between 1983 and 2006. They found that 31% had reported having left the profession, 12.7% reported an intention to leave the profession within a year, and 4.6% had already retired. So if you add up those numbers, it actually equals out to more than 50%. So there's some real concerns about, are we able to retain the folks that we're training, not just within aging, but across the profession. Is that a shock to any of you in the field? So, you could argue that some turnover or some loss of workers is good, and certainly, we don't want to keep people from retiring that that want to retire, and it is a women's profession, so some folks go off and raise families and so forth. here in Ontario, the OASW, Ontario Association of Social Workers, conducted, I think about 5 years ago, a quality of work life survey. This was a survey of over 1,000 social workers across the province, across all specialization areas. What they found was that a high degree reported experiencing high levels of stress, 63%. And then areas that the stress impacted on included family and social life. 37% reported feeling depression as a result of job-related stress. 38% reported irritability with colleagues, and about a fifth with their clients. 35% reported having an illness that they felt was related to their job or related to stress. 19% were concerned about making too many mistakes on the job, and 57% reported feeling rushed, and reasons for that included staff shortages and high volumes of work. And it's always the case when you interview social workers about their jobs that they'll tell you that they're not paid well. And I guess you could argue what a good salary is, but in this particular study, 1/3 reported that they had to have more than one job just to make ends meet.
Can I just ask you, would those figures differ depending on profession? I mean, is that what everybody's feeling, or is that just social workers?
I don't know. I didn't look at other areas of literature.
Managers or
I would imagine it's probably the case across, health services professions or helping professions. But yeah, I could go back and.
I just wondered if it's worse for social workers.
Good question. We'll look that one up. Nursing, maybe. Yeah.
The previous slide that was showing the higher the number of grades and percentages of people that are leaving the profession, is it because there's a higher rate of burnout for social workers working in the gerontology?
I think this particular article, if I remember correctly, was stressing sort of the caregiver component. So either child rearing or care for elderly parents. The literature on burnout is like a whole other kind of piece that I tend not to focus on because it has more of a psychological element. And then just to finish up on this particular survey, while most of the social workers that they interviewed or surveyed stated that they had supervision, an important clinical resource, 28% reported having no clinical supervision. Average career satisfaction was somewhat in a modest range, 6.85 out of 10. So if you want to look up any information about this particular survey, I've cited the two main sources for this. So again, this is Ontario-specific research related to social work and aging. There's been a trend, for those of you who have exposure to hospitals here in the region, towards program management. Is that a new term for any of you? So traditionally, hospitals were organized by professional groups. So you would have a social work department, a nursing department, department of medicine, and so forth. What program management does is sort of do away with these professional departments, and so each interdisciplinary group falls under one specific program. So at BCREST, we just went through this process a couple years ago. So if I'm a social worker in the long-term care units, my immediate supervisor is not going to be a social worker. It might be a nurse, for example, which is good in a sense because it forces folks to work in more of an interdisciplinary fashion, but it also means that you may not have direct access to professional resources. So this study, which was conducted in one major hospital here in Toronto, looked at some of these issues. They found that social workers reported spending more time with their patients, which is good, but also reported less job satisfaction. So they were asking, well, why is this? Social workers want to spend more time with their patients. Why are they less satisfied in their jobs after this switch to program management? So what they found is that the social workers reported less social support from peers and opportunities for collaboration, fewer opportunities for things like research, teaching, and professional development. They felt less recognition within their hospital, and a perception that workload demands had actually increased. And we found this good statement from this particular article that hospital social workers must now be comfortable practicing in a very independent manner and be prepared to assume all responsibility for adhering to professional practice standards and advocating for oneself. So it's, it's in some sense that the professional support that they have in place might have eroded. In terms of my study, so building upon some of that research, this is the first known study of gerontological social work in Ontario and all of Canada. To my knowledge, there might be smaller studies that are published that I didn't find. Two general aims of the study: to identify factors influencing job satisfaction and organizational commitment, and provide descriptive information regarding Ontario's social work workforce and health and aging. And today I'm here to focus on that second piece because I have actually not collected the data on job satisfaction and organizational commitment. That's the second and third waves of my survey. This is the overall model that we're testing. So it's a structural model of organizational commitment. The issue of burnout was raised. I prefer not to maybe look at some of those more psychological characteristics because I'm interested in being able to make recommendation in terms of workplace factors. So in terms of some of those structural characteristics, we have items related to workload, resource inadequacy, role conflict, role ambiguity, routinization, which is that sense of I do the same thing day in and day out, autonomy, which is their level of independence in the work that they do, promotional chances, supervisor support, coworkers support, and distributive justice. So where you see in the negative and positive, that has to do with the nature of the relationship to job satisfaction. And then we're controlling for some worker characteristics, including competency in aging, general training, involvement, and negative affect. Now the competency in aging piece, that's actually on the second survey, which we'll start doing data collection on that next month, and that's a self-rated measure of competency. And then finally, the two outcomes we're looking at again are job satisfaction and organizational commitment, and we expect job satisfaction naturally to be positively related to commitment. And these, I know this is kind of just restate what I just went over. And I'm happy to share these slides with you, because that's that up front. So in terms of my overall design and methodology, this is a longitudinal design, data collected in 3 waves via the internet. The reason that it is longitudinal is to try to reflect those 2 or 3 stages of data collection. So in other words, to be able to say, it's still not a causal model, but to get closer to causality for those of you who've taken research methods and say, for example, well, higher workloads might predict less job satisfaction and so forth. The surveys have been pilot tested at Baycrest. Again, we've just completed the stage 1 phase of it. We mainly recruited to the Ontario Association of Social Workers. Secondly, we've been able to collect some registrations through, there's a regional, or I guess it's provincial professional practice network for social work and aging. And then the regional geriatric programs of Ontario have also been kind enough to advertise our study through their listserv. So social workers would get an email from us inviting them to register for our study along with the criteria. And within that email, there's links to our registration page, which is hosted by the whole survey process is hosted by SurveyMonkey. And 3 online surveys taking place 6 months apart, 0, 6, and 12 months. And on average, the first survey is taken about 20 minutes to complete, and the second 10 minutes and 5 minutes. So really, trying not to be too much of a burden on time. Inclusion and exclusion criteria this is a study exclusive to social work, so we didn't look at social services workers, which is another component of social service workforce in the province that would provide maybe similar services to our profession. So that could be a secondary study that I would do. The study is only eligible for current practitioners who provide clinical services to adults 65 years and older. Having said that, they didn't need to be a specialist in aging. They could be, let's say, for example, a child welfare worker who has kinship care providers or so forth. Having said that, my sense of the data is that we did tend to capture aging specialists, and that might just be by the very nature of how we advertise the study. It's difficult to do a broad study and then say, well, but we want you to have older adults on your client caseload. They needed to be employed on a full-time basis, and that's because we were testing job satisfaction and commitment. You can't really compare people with part-time jobs to people with full-time jobs. It's just a different population. And social workers will be disqualified at surveys 2 and 3 in the event that they change jobs or change employers. We haven't crossed that line yet to see how many that will happen to. Hopefully not too many. So this gives you, again, a sense of how we're grouping the data across surveys. I think the model kind of catches that too, and I've already explained that to a degree. So today we're focusing on the descriptive data from Survey 1, which is the demographic, training needs, tenure, and experience, roles, functions, salary, type of setting, job design characteristics, and worker characteristics. Measures that we used mainly come from the work of Price. There are 5-point scales, Likert scales that measure extent of agreement and disagreement. The scales each have about 4 to 6 items per each. So again, my concern with not having really lengthy surveys that folks had to fill out. And just as an example item, to give you a sense that these are attitudinal in nature, one of the job satisfaction items reads, I am fairly well satisfied with my job. 1 equals strongly disagree, up to a range of 5 for strongly agree. We take the average score across items, and internal consistency, reliability has generally been good for these measures, and including in the present study. So on the second phase, we'll be collecting this data on geriatric social work competency, which comes from the Hartford initiatives in the states. It's a self-rated measure of geriatric practice competency. It's generally been used with students to evaluate their sense of competence in doing field work. There's 4 subscales to this measure, and I'm only looking at the assessment and intervention subscales. I think the other 2 are related to ethics and policy. So an item from this measure, conduct a comprehensive geriatric assessment, biopsychosocial evaluation, and social workers can rate themselves as not being skilled at all. We hope that that's not the case. Or having expert skill, which would mean that they feel competent to teach it to others. And then there's an item related to general training, which will be a combination of social work credentials and paid professional experience. So here we go. Preliminary research findings. At this point, we've recruited 124 participants. 100 of these folks were recruited through the OASW, and then an additional 24 were recruited through the other networks that I described. In terms of demographics, I think we have generally a sort of middle-aged population of social workers. I think that might be the case generally in our field. Largely female, again, we do tend to have a generally female workforce. And marital status, most are married. In terms of demographics, generally folks are white, and then somewhat of an even split among the other racial and ethnic groups that we surveyed. Service settings, I believe this was an item where they could do a sort of check all, because we realized, well, we can't be exclusive here, but for the most part, people were reporting being based in hospitals. An equal number were based in outpatient geropsychiatric programs, and that other 17 is other, and then you can kind of see the split goes down from there. We did an analysis of job title. There was a piece where they could just write in their job title, and over 50% reported having a job title of either like social work or case management. 17% reported working as a healthcare social worker. That included things like oncology, nephrology, for example. About 14% reported working in a mental health capacity, psychotherapists, clinical social workers. 10% had some kind of job title that indicated they were a director or a manager of some type, and then 6% were other types of job titles. In terms of degrees, the vast majority were MSWs, had not had specialization in gerontology as part of their university training. Most were members of the college, and about an even split were unionized and non-unionized. In terms of experience, I think we caught a fairly experienced group of folks here, and it might just be the nature of how we sampled. You could see a sort of even distribution, and all of a sudden we have folks in the 15-year or more category who comprise the majority of our sample. And the same comes with gerontological experience. We have a fairly experienced group in terms of gerontological experience.
Can I just ask?
Sure.
When you say there hit the number of people with 15 years or more, was that all in gerontology, or was that just being a social worker?
Here, I think what was the question? How many years of experience?
People who have 15 years or more,
Mm-hmm.
did they spend that 15 years in gerontological social work, or
Yeah.
were they just social workers and some of the time was?
Well, this question was just how much experience do you have in social work in general? The next item was how much experience do you have in gerontology? So I suppose we could go
I'm
back
sorry.
and
Okay, gerontology experience. Okay.
yeah, with the elders. I suppose we could go back and see, how much correlation might be there if these are folks that have just been working in gerontology all this time.
Well, because it just strikes me they must be pretty satisfied if they've worked 15 years in gerontology.
Yeah, that's a good point. In terms of tenure, it's more of a reasonable distribution here. So these were scaled items. We didn't ask for years necessarily. Income, again, I don't know if I would call this an even distribution or not, but you can see somewhere in the range of 60 to 80,000 tends to be typical income. Again, caseload, there does seem to be a kind of skew here, although we didn't report that. So the largest categories being between 11 and 24 and 25 to 49. And I think that was the caseload at that particular point in time that they were surveyed. So we did find some interesting results in terms of clinical supervision. If you think back to that OESW survey that I talked about, and they had a fairly large number that had no access to clinical supervision, and when we found that we had an even greater percentage that had reported no access to clinical supervision. Of those who had access, 42% reported that they were clinically supervised by a social worker. This is their direct supervisor. Another fifth reported being supervised by a non-social worker, and then 38% apparently had no clinical supervisor and were seeking their supervision from elsewhere, like no internal supervisor. So we had a couple open-ended questions related to this. These are the folks that reported having no immediate supervision in their workplace, and the range of folks that they were receiving supervision from, and you could see that there's quite a bit of variation in terms of who they're seeking supervision. So psychologists, RNs are providing supervision to social workers, OT, PT. Some are I guess, paying for supervision. So you see some receiving supervision from other MSWs, professional practice leaders. So we're still working with this particular data. And there were some interesting comments related to program management. We did a little control find to see how many folks actually mentioned program management in their comments, and there were 11. And for the most part, these were negative points, but related to supervision, one person said the hospital functions under program management. There is a discipline leader, however, it is not her role or responsibility to supervise social workers. Second person said the position of supervisor was discontinued once the Department of Social Work was dismantled because of program management. We do not have access because no head of social work or official professional do not have access because there is no head of social work or official professional practice leader. My position falls under program management and so forth. So again, it's getting back to that issue of having access to clinical resources in this type of environment. And then another group of social workers reported receiving peer supervision. The first person reported, I have a supervisor in the rehab services, but she is not a social worker, and often I consult with my peers in my college, especially regarding ethical issues. The second person reported, the organization I work for does not provide clinical supervision arrangements. My colleagues and I provide informal clinical supervision on an ad hoc basis. So it seems like peer support is an important part of the clinical supervision for a number of folks in our study. So we had an item about job tasks. Can't remember how this was scaled exactly, but what we're presenting are the job tasks that are reported most or all of the time by social workers as tasks that they spend the most or all of their time on at work. So a large majority spend most of or all of their time on direct services. About half reported spending most or all of their time on administration. And the numbers kind of fall off from there, but you could see some of the areas that, I think these are questions from the NESW workforce study in the U.S. So we asked about professional development, discharge planning, teaching, and so forth. We also asked about opportunities for continuing education or training within the past 2 years. Large majority reported being able to attend conferences or workshops on the job training, and then smaller percentages reported participating in certificate programs, professional association programs, credit courses, distant learning. One person said they had received no additional training in the past 2 years. Top 10 training needs. We had a laundry list of training areas, and we're reporting the top 10 here as reported by the social workers in our study. So mental health seems to be a big training need. Ethical issues and aging, reported by just over half. Psychosocial interventions, just under half. And then from there, aging in the brain, end of life, planning and care, bereavement issues, communication between older adults and their families, alcohol and substance abuse, advocacy, and multiculturalism being the 10th most common.
I have a quick question.
Sure.
In terms of bereavement, do you think they were referring to their own training to deal with their own bereavement, or do you think they were thinking in terms of helping others?
I think it's the latter. I'd have to go back and see how we asked that survey item, but it might just say bereavement, which is how I tend to interpret it, but it's a good point. And then just examining the characteristics from the theoretical model that I presented to you. These are in decreasing order. If we treat, since this is a 5-point Likert scale, if we treat this as continuous variables, the highest mean was for role clarity. So for the most part, social workers in our study felt that their roles in their workplace were clear. And then the lowest being routinization, 2.19. So for the most part, folks felt like they had variety in their work. And these were those control variables that I spoke of. So for the most part, folks in our study seemed to have more of a positive affect than a negative affect. 2.4. The job involvement items are fairly strongly worded, so they're questions like, my work is my life kind of thing, and so for this to show up as 2.4 is not terribly surprising to me. And just to kind of show you the distributions and treating this again as 5-point scales. the autonomy, the mean is about 4. Distributive justice kind of falls somewhat around the midpoint.
So what do you mean by distributive justice?
Oh, sorry, that's their feelings about how they're being paid. So there is a question about salary on the survey, but then there's items about, do you feel like you're being adequately compensated, and that includes your benefits. There's 4 questions about that. And related to that, there are opportunities for promotion within their organizations. Supervisory support, so that's their items about their direct supervisor, who again might or might not be a social worker. And you can see this is kind of a bimodal gang distribution. So it appears that a lot of folks feel strongly that their supervisor is supportive, and then the rest is sort of more evenly distributed. Same goes for coworkers support. And we didn't really define what a coworker was. We had some comments about that afterwards, so in my mind it's sort of your immediate coworker unit. Routinization, again, falling more on the low side of the scale. Resource inadequacy, I think that had to do with things like office space and so forth. Little conflict. Are they being asked to do different types of roles and functions that might be in conflict with one another? Real clarity, do they understand what it is they're doing in their work? Is their job description well defined and so forth? Workload, that one looks kind of wild. Job involvement. So we're starting to get into playing around a little bit more with our data, and we're not at the point of running any multivariate analysis, but I thought I could sort of do this intercorrelation of the items or the scales from our theoretical model, and you can begin to see where there are some statistically significant correlations. So I tried to highlight the ones in red. Yeah, it's pretty clear up there. Some of the stronger ones, let's see, autonomy is negatively related to routinization at 0.44. It's also negatively related to role conflict, and so forth. So the ones in blue are significant at the 0.05 level. Coworker support is negatively related to role conflict, 0.524, a moderate correlation. Role clarity, as we would expect, is negatively related to role conflict, 0.6. So eventually we'll test that whole model with a multiple regression analysis. This, you can run just for the point of looking at the correlations, but also as a test of multi-collinearity, and isn't appearing to be a problem here. And then we had at the end of our survey a comments box, and I went through this yesterday and tried to pull out some, comments that I felt were salient in terms of the workplace, describing the workplace. Here's one person who said their hospital is dominated by nursing staff. Inpatient psychiatric nurses resent the multidisciplinary approach. Assessment and therapy with patients is considered to be a nursing domain at my hospital. She or he also spoke about social work being there for discharge planning. So there's this sort of sense of competition between professionals, perhaps. This person had a lengthy quote. Point I think she was trying to make is that there's this not much of a differential between what BSWs and MSWs are being paid. She'd spent the first part of her career in some other type of practice setting, I can't remember what it was, and then went to a hospital where suddenly she was making quite a bit more money, but being paid at the BSW level range rather than the MSW level range. So at the end, she said, the biggest concern I have is the loss of what I have been contributing to my pension. This is the first job I've ever had where I'm contributing to a pension. So there's, again, that sense of distributive justice and adequate compensation field. I felt like this this person sort of captured some of the issues I talked about earlier in the presentation. She said one area that prevents registered social workers is that we are not considered a part of medical professional services and are undervalued and not recognized. There's a need to be addressed by the College of Social Workers and School of Social Work. So again, sense that the profession itself is not valued because we're not maybe treated equally as peers to other health professions. This person said some of the survey questions highlight workplace concerns which I've had for some time, namely poor management styles. My manager is different from the one who manages the department I work in. And the management and leadership I receive are very weak and negative. The social workers in our hospital, unfortunately, are very weakly led, and there's next to no cohesion. So without having gone back and looked at the data set, I'm not sure if this person works in a program management setting or not, but it sounded that way from this quote. So this brings us to the discussion. I don't feel really prepared yet to say this is what my study means and these are the implications, because I don't think we're quite there yet. But I'm starting to glean some impressions of the data. Thought we could maybe focus on this particular slide as a group and talk about some of these issues. First is the sense that I have that gerontological social work is being provided within the context of health and mental health settings, which makes sense. What I'm wondering, someone who's only been up here for 4 years doing research, is to what extent is gerontological social work its own discrete practice specialization? Are we providing services to older adults as healthcare workers, or are we providing workers to older adults as gerontologists? Yeah.
I worked at a community care agency that dealt specifically with seniors,
Mm-hmm.
and it was seen very much as as discrete job specialization because of the required for older people, the chronic issues, chronic health issues that they have. We also worked a lot with caregivers. Now, I'm sure there's other populations of different age groups that would have similar problems, but in our society, the majority of those people are older people. So it was.
What is the student viewpoint on this? Are you all specialists? Are you all in gerontology concentration? Or?
I'm doing a student placement at Hospice Toronto, and the two clinical directors, client service coordinators there, are both social workers. But with hospice work, the client population isn't necessarily people in the elder community. I mean,
Yeah.
we're seeing people from all ages. The two social workers that are there, I think they have a special interest in specifically in elder issues, or issues that face the elder community. I don't know what their histories are like with working with gerontology specifically. Being a layperson to this, like what I'm being faced with as a student is my own conceptions of what aging looks like, and specifically like the fears that old people face when they are getting older, and looking at, for example, like the changes I see in my own parents and caregiving roles. This is sort of like a new concept for me, but it's an area that I kind of am interested in.
Well, I guess my own sense is that it's an emerging specialization here in Canada, and we'll be hearing more about it. And then again, some of the comments that were coming from the folks that completed the survey was the sense that maybe social work is undervalued as a health profession, and that could be related to the way the regulations are written and the fact that we're part of a different college than the other health professions. So I'll just put that out there as a possibility, and maybe I'll know more about this in a year when I've collected more data. Another theme that seems to be emerging, again, reorganization of care systems, so the broader healthcare system. and care environments, and how that impacts social workers' on-the-job experiences and access to clinical resources such as supervision. Just looking at the sample descriptives, demographic descriptives, this, at least in my study, seems to be a fairly homogeneous workforce, providing services to a potentially diverse client base. And I'll know more after survey 2 of the type of clients that they're surveying. Just given, especially the Toronto population, this is a diverse, ethnically diverse population. So what are the implications for that in terms of practice? And what are your experiences in providing services?
Let me go back to the supervision question, because it's interesting to me that lack of supervision is understood as a problem, because lots of people would see it as a solution. Right?
Well, I think, going back into the comments again, there are folks that are probably experienced enough where they don't need the clinical supervision. I guess you could argue it either way, though. It's always going to be a new case that you've never seen.
Why is it clinical supervision only?
In our survey, we do make that distinction only because my sense is that everybody needs some kind of consultation around clients, even if you are an experienced person. It might be a case that you've never seen before you need to access.
It's interesting to me because if you're using autonomy in a particular way, then what's the relationship between supervision and autonomy, and between colleagues, as colleagues could be those with whom you consult as opposed to people supervising you? I mean,
sure.
If what you're looking for is somebody to talk to about it, it doesn't have to be a supervisor.
Oh, I agree. Yeah, that might be, the next, if I ever do a study like this again, items to add would be around maybe peer supervision, since that didn't seem to emerge as an area within the comments.
But it seems to me that it's also related to this question of workload, because there's another question about the extent to which you work alone versus, there's a difference between working alone, autonomy, and supervision, I think. Those are three different.
Yeah, this all cuts both ways.
Yeah.
Autonomy is good in the sense that people feel like they can, have a sense of being able to do what they want to do when they want to do it, but not if they're working in absolute isolation. Yeah.
I worked as a manager of social services, so I was doing clinical supervision team. We had 5 social workers, and it was a difference between the peer support and then the work that I did with them one-on-one. The peer support was more around, does anybody know about a resource that could help my client with their free income tax preparation, that kind of thing. And then when they would come and see me on their own, it was more to do with, as you were saying, a case that maybe they hadn't seen before, a client they were feeling too emotionally involved with to perhaps be able to be detached from what was going on. A sense that they needed just some guidance in how to handle the psychological aspects of it. So the peer stuff was more instrumental, and then with me it was more clinical.
My question had more to do with how they answered the question.
Oh, I see what you're saying.
In the sense of what did they mean by autonomous supervision and the workload, well, who you worked with. You did ask them a question about how many others they worked with.
That's on the second survey too. I can't remember the exact item, but it had to do with how many other social workers are in your program or unit. And I could share with you if you want to the actual items for autonomy. I just don't recall them right now. Any other issues around
I'm wondering, you're at Baycrest.
Yeah.
Is Baycrest a very particular kind of place for social workers? And you get a different sense of what specialization might mean operating in that setting versus the settings where a lot of other people work. I know a lot of social workers with whom I deal are certainly experiencing the undervaluing in health settings and in other settings. job protection, wherever else they are. I don't get the sense that a lot of them seek specialization in gerontology. They mainly work with old folks.
Yeah.
If you're working in a hospital, you're likely working with old folks, but they don't see that specialization as being important to them in ways that might resonate better at Baycrest. I wonder if you got any reflections on that.
Well, I'm probably showing my bias by even talking about it, but I don't know. I haven't really gone around to ask the social workers at Baycrest whether they specialized in aging. I would gather that many of them have and many of them have not. I did not as part of my MSW program. I don't know, to the extent that it advances your professional self and doing aging-related work, it could be a good thing. Otherwise, people learn a lot just from doing the work. And there's nothing wrong with that either. And certainly, to the extent that they do continuing education kind of opportunities, that furthers knowledge and skills too. So.
But your sample's not just from Baycrest, right?
Oh no, that's province-wide. But yeah, you're
No, but
talking about Baycrest as a special case,
Yeah,
which
right.
we are.
I'm interested in the kinds of questions you're posing. I'm wondering about the extent to which they are informed by your location.
Oh, I see. Probably more informed by previous studies that I've done outside of Baycrest. I did a very similar study to this for my dissertation, which was looking at turnover of social workers in long-term care. So.
Which raises another issue, since the previous study presumably was done in the States.
Yeah.
And there is more emphasis throughout healthcare on specialization in the States than there is in Canada.
That's true, yeah. Yeah, so, specialization is not anywhere in the model. It's just kind of a question that I asked. And, it's not to slight those of us that haven't specialized in geriatrics. It's just...
I certainly heard a lot about health professions regulation,
Yeah.
excluding social work, and where it has come up with social workers I've talked to is around access to research funds and opportunities, and how because they don't have the ready access that the health professions that are organized together under HBRAC have, they don't get time, they don't get value for doing research, they do it on their own time.
Yeah, I think, well, again, I might be biased, but I think it might be easier to get funding for nursing research, for example, than social work research and gerontology. And I was very happy to get funding through SHRC for this study. I think the Ministry of Health has given out some funding for interdisciplinary type of projects, maybe more smaller scale and not so much workforce development projects. But yeah, I agree with you about that. Questions? And then the final issue that came up for me in looking at this, again, this initial wave of data is to the extent that my sample is or is not representative of who's providing gerontological social work in the province. Are we going to experience a loss of older social workers, more experienced social workers to retirement? If you look at some of the earlier trends I showed you in terms of experience age too, that made it in there. So we have a more middle-aged population in my study and more experienced in terms of providing services to older adults. So what is that going to mean in another 10 or 20 years? At the same time, Canada's aging population is going to double. Are we going to have this wave of retirements coming? So that's something to think about.
Not directly related to that, but I'm just wondering if you've thought of comparing social workers working in different settings, seeing if the response is different. Because I would expect that perhaps social workers working in hospitals may be more likely to be unionized and have better job protections than social workers working in other settings.
Yeah, no, that's a good point, and I toyed with the idea of doing some of that kind of analysis for this talk today, and then I shied away from it because I thought, well, I'm getting a little too ahead of myself at this point. But yeah, I will take a look at that. And I think the union piece is especially interesting to me, coming from the States where social workers tend not to be unionized, and here I have this group that's sort of equally unionized and not unionized. And so I'll definitely look at some of those characteristics.
Did you ask them what unions they belong to?
did. I could. I just feel like that's a great need. So there's still room for me to add items on my second and third.
It is really more important to know if their workplaces, if they're covered by collective agreement. Because lots of Canadians are covered by collective agreement.
Okay. So at this point, I'm feeling like the biggest limitation here is in terms of sample representativeness. And I struggled quite a bit in writing the proposal and doing this survey and how to access social workers that are not connected to professional associations and networks. And I think that's just a general issue with doing this kind of workforce research in Ontario, I would guess, most of Canada. So there was not a good sample frame for me to access to do this study. I had to go through the OSW, which probably tends to be a more highly professionalized group than what you would normally find in the community. Again, I also did not look at social services workers, who are those folks that have 2-year degrees and doing social service work. That might be a secondary study. And again, I did not look at consultant only or part-time workers, just because it didn't really fit the kind of theory that I was testing. This kind of gives you the time frames for the next wave of data collection. So I had offered to maybe come back in a year or year and a half to tell you what the final outcomes were in terms of job satisfaction and commitment. I would be happy to do that if I'm invited back. Are there any other questions?
I just have one based sort of on the gentleman's question.
Sure.
In your own experience in doing this study, do you get a sense that gerontology should be a specialized field, or do you feel that it's essentially part of social work, and that really the age, it doesn't matter, that anybody across the life course that needs care needs care? I'm just wondering what your thoughts are on specialization.
Yeah, well, my bias, again, coming from the States, there's been a tremendous emphasis on developing the gerontological social work workforce in the U.S. And part of that, or a large part of that, is due to the John Hartford geriatric social work initiatives. And they've invested millions of dollars into social work, nursing, and medicine to develop the research and infrastructure in gerontology and geriatrics, as well as faculty development and a certain amount designated just for field placements for students. So my own bias is that it is a specialization and should be considered as such. And then, no one in this room, I think, would argue that older adults are, their own particular group with their own set of developmental issues. We should all have knowledge about what those issues are and what their health needs are, for example. So yeah, I think I'm a fairly strong advocate for gerontological social work as its own specialization. Having said that, we work within health settings for the most part and in social service settings. So I don't think that means that we don't talk that language either. But I don't know what's helpful to you all in terms of that.
I'm just wondering how many, do you find a large number of master's students focusing their work in this specific area? Or is there like a disproportionate amount of social workers at the master's level focusing on other areas? Because I'm just wondering, because it is very highly targeted.
Yeah, I wish Lynn McDonald was here, but yeah, come on.
I'm actually a student in the gerontology specialization right now. And our class it's the smallest of the 4 specializations, and I think there's like 35 of us. Whereas last year maybe there was 12. So it is a growing specialization, definitely, but it is a lot smaller. But I'm noticing a trend where people are more interested in coming, like there's electives and people are actually coming out to them, so it's growing.
Yeah, my sense in the States is that this didn't really all take off until 10 years ago when the Hartford initiatives developed, and there has to be maybe a sort of parallel type initiative here in Canada, if we can find the money. What else?
Thank you.
Thank you.
I have a little token.
So you need to get your iPad.